Hello, I am Dr. Carlos Blanco from the National Institute on Drug Abuse. I want to thank you for joining me and my co-panelists on this session of sustaining behavior change. I'm going to focus on substance use disorders, but I hope that many of the lessons that we discussed in this presentation and the following discussion will be applicable to other behaviors and disorders. I'm going to focus on three questions. Why does most behavior change fail? Then what needs to happen for behavior change to be sustained? And finally, what studies are needed to make progress in this area? So the first question essentially is, why can't addicts just quit? And of course, it would be great if it were so simple and we could just ask them to quit, or if they just wanted to quit and immediately they could do it. Obviously, the fact that they cannot do it and they don't do it suggests that the situation is much more complicated. Just to provide some context, we can think of addiction as a disease of the brain. The same way that we could detect metabolic changes and structural changes in the heart of somebody who has heart disease, we can find changes in metabolism and brain structure in individuals who have substance use disorders. Now, even though the common final pathway of substance use disorders are changes in the brain, there are many factors and many risk factors that influence this common pathway. So if we start thinking, for instance, at a very simple level, we have a genetic makeup, a genetic predisposition, then those genes get expressed into the development of the organism of the body. There are other aspects of the biology, for instance, hormonal influences, microbiome, any number of other biological influences. No organism lives in isolation, no mind is an island. So we all live with peers and with family. Our peers and our family influences, especially in high school and in late adolescence. Families don't live by themselves, but rather they live in neighborhoods and communities. And finally, those communities are influenced by cultures and law. So we can see a variety of levels, all of them interacting. So for instance, when you think about genes, genes don't produce their effect in isolation. Even if you think about identical twins, which have the same genes, they are not identical. I mean, they are not identical in their behavior, and that's the consequence of the different interactions that they have, how they develop, what kind of things they do, and what happens to them, sometimes randomly in their lives. So they may meet somebody, or they may have an accident, they may have disease. So the overall point is that there are many factors that influence our development. And I mean, first of all, our normal development, but you think more specifically about behavior change and behavior in general, all these influences are going to shape psychopathology. If you think a little bit more, if we think about a little bit more deeply, there are many influences at many levels and at many stages of development that, determine essentially, or at least influence how the individual develops. This is a model that we developed for substance use disorders, but is applicable across a broad range of behaviors. Each color tier indicates a stage of development. So the green tier refers to infancy or even prenatal development. The red tier indicates childhood. Blue would be early adolescence, then late adolescence, and finally current adulthood, essentially. So this is a way to illustrating how there are many multiple pathways by which people can end up in the final pathway of substance use disorders. For instance, there's the predisposition of family history. Some individuals are victims of sexual abuse. Some individuals live in families that may not be fully functional. All these things interact. So obviously, a family history of substance use disorder is going to interact with the probability of being a victim of sexual abuse. And those are going to sort of cascade. It's going to be a cascade of risks. So for instance, the person who, just to give an example, the person who is a victim of sexual abuse is going to be more likely to have high impulsivity, low self-esteem, and potentially early onset anxiety and early onset substance use. And those things, let's say this second tier, the individual who is impulsive and have anxiety and substance use is more likely to have a lower educational achievement, probably because of the impulsivity, potentially the substance use and intoxication, may expose themselves to risky situations and be more likely to suffer trauma, more likely to develop psychiatric comorbidity. Of course, the history of trauma and psychiatric comorbidity may lead to social deviance or even increase further the risk of substance use disorders. And I mean, this is just one example. So there are many, many pathways by which all this can lead to substance use disorders. And all these paths and all these risk factors, what is telling us is that there are many things that are shaping behavior in one direction. And by the same token, they're going to make it more difficult to modify that behavior, to change that behavior. And even in the case when the individual is able to modify the behavior to sustain change, because all these risk factors are going to be essentially forces that push the individual, that pressure the individual to move in a specific direction. And so one way to sort of integrate these risk factors is to think that there's sort of one pole where would be the biology, the gene, and another pole that would be this very complex environment that interact with each other and are going to predispose the individual to using drugs or alcohol. Now, the drugs and the alcohol are going to have an effect, obviously, on the brain, and there will be brain modifications that will sort of embed the behavior of addiction or substance use disorder. Now, as you can imagine, the brain is a very complex organ, and so it's not that the genes or the environment are going to act only on one part of the brain, rather they're going to act on different aspects. And so maybe one easy way to think about it is that obviously in the short term, substance use, be alcohol or drugs, produce rewarding effects. That's why essentially why people use drugs, because they're rewarding on the short term. So they're going to create modifications in the way the reward system works. But it's not only the reward system, there's also aspects of inhibition. So on the one hand, there will be part of the brain that is telling us to use drugs because they're rewarding, but there will be another part of the brain that say, well, you know, hold on, this is not good, this could lead you to bad consequences. At the same time, there's another part of the brain that we could say sort of the referee, if you will, which is the executive function, and is going to try to balance this push on the reward and this sort of control of the inhibitory functions. And there's going to be also a component of memory. So it's not only what we feel right now, but also what we remember from the past. And all these things are going to be interacting. So when we think about vulnerabilities for substance use disorders, we can think somebody who may have excessive ability to get reward, if you will, or deficits in inhibitory control, or they may have problems in this sort of referee part of the brain, or they could have a biased memory or a very intense memory for the rewarding aspects, but not such a good memory for the adverse consequences of the drug. So when we think about behavior change, all these things are going to be interacting. And even if, let's say, momentarily the executive function is able to move somebody towards the inhibitory control and try to avoid the reward and the adverse consequences, again, because these things are sort of embedded in our brain, they're going to push back and try to avoid that the behavior change is sustained. In addition to the brain aspects, and I would also like to point out that in the addiction we can also think of three sort of different aspects. One is the rewarding aspect when we consume the substance. Then there's a withdrawal aspect, and so one pushes to consume to get the reward. But there's also another push to avoid the withdrawal. No? And a very easy way to think about it is being hungry. When somebody is hungry, you want to not only enjoy I mean, there's one aspect that would be enjoying the food, but the hunger is also something that is pushing you to consume food to avoid, if you will, the withdrawal. And then there's an aspect of anticipation of what's going to happen. So in the addictive cycle, we have these sort of three components: the positive reinforcement of the reward, the negative reinforcement of avoiding the pain or withdrawal, and then the anticipation of the next consumption. But in addition to the brain mechanism that I just outlined, we also can think of the availability of substances. And so, for instance, in the case of the opioid crisis, which is in the mind of all of us, the availability of opioid prescriptions increases since 1999 until probably 2014, 15. And so the availability of the substance is also going to determine our propensity to consume. And in terms of behavior change, even if you're able to stop consuming, the availability of substances is going to be a trigger that is going to remind you that this is available, that you can use it. And so it's going to deter behavior change. There's also the aspect that we are also conditioned by our history. So in this diagram, what I want you to focus on is on this central aspect of the substance use disorder and how it has many consequences. So it has ability, probability of divorce, problems with neighbors, violence. And so these things that initially can be the consequence of substance use disorder potentially can become also triggers, because as the individual tries to sustain the change, the individual may have, let's say, poor social support, or could be unemployed, or could have lower income, or poor physical health. All these things can become stressors that lead the individual to want to consume again and therefore have difficulty sustaining change. So in the first part of the presentation, I have outlined a little bit of the biology or the interactions that made behavioral change difficult. So what is that we could do, or what can be done to improve the chances of sustaining behavioral change? Well, there are a number of things that can be done. One is act in a very, very clear biological way with medications. So in the case of opioid use disorder, we have very effective medications that, if used, can help sustain the behavioral change, essentially abstinence from opioid use. Not all disorders or not all substance use disorders can be treated with medication. So another avenue that we have is psychotherapy, and there are different types of psychotherapy that are outlined in this slide, and some of the mechanisms that these psychotherapies can target. So, for instance, given that the drugs have a rewarding effect, one way would be to use contingency management, which provides alternative rewards, and so we can create sort of in the brain a struggle or a way of decreasing the pool of the rewarding effects with these alternative rewards. Another way to sustain change is to provide cognitive behavioral therapy that would improve the executive function and the inhibitory control. We could also act on increasing motivation using motivational interviewing and other therapies that might strengthen the prefrontal and striatal communication. We can also interfere with conditioned memories or create new memories with biofeedback or behavioral therapies. And finally, as I was mentioning before, there are adverse consequences from using drugs, and many of these consequences are going to be essentially stressors. So we can also try to decrease the stressors that are one of the triggers for relapse using relaxation and also behavioral therapies. So one way, as I mentioned, was medication. The second way is psychotherapy. And then we can also use other non-pharmacological treatments, such as TMS, transmagnetic cranial stimulation, transcranial magnetic stimulation, transcranial direct current stimulation, and also deep brain stimulation. Some of these therapies are still in early stages of testing for substance use disorders, but theoretically that would be one way to improve the outcomes. Now, one of the questions that also come up often when we think about behavioral change is this idea of switching addiction. So one of the fears is, okay, if you stop one disorder, or if you generate a behavioral change, is that going to then lead you to an addiction? Well, the empirical evidence is that if we are able to change one behavior, that is going to favor the ability, increase their ability to change other behaviors. So in the case of addiction, individuals who are able to quit from one addiction or remit from one addiction are much more likely to remit from other addictions 3 years down the line, much less likely to relapse from addictions from which they had remitted previously, and also decrease the likelihood of new onset of addictions. So probably that has to do with a couple of things. One is that the individual who has remitted from one addiction has increased motivation, but also in one way or another, they have strengthened their ability to engage in behavioral change. Consistent with this finding, if you will look at the time course of relapse, we see that there's always a risk of relapse, which essentially, relapse is the same as not being able to sustain change. So there's always a risk of relapse, but as you can see, this risk decreases over time. I've put here a graph to exemplify it with smoking, and I'm sure that in the clinical and even daily experience of all of us, we see that people who have been able to remain abstinent from smoking for a period of time are much less likely to relapse. The people who relapse generally do relatively shortly after quitting, but the longer people are able to remain abstinent, the less likely is that they are going to relapse. So again, the longer we are able to sustain behavioral change, the more likely is that the person is going to maintain change. And that again probably has to do with increased commitment to change, decreased adverse consequences, increased quality of life, and even there are some indications that there's increased sort of a strengthening of the brain, if you will, a healing of the brain. We don't have good longitudinal data on this, but the available evidence suggests that as people are able to abstain from using drugs and remit from substance use disorders, there are changes in the brain that indicate a normalization of their reward circuitry and also an increase in behavioral control. Now, the other thing I wanted to emphasize in this talk regarding behavioral change is that what I have mentioned in the last few minutes, medication, psychotherapy, non-pharmacological treatments, in a way are therapies that we can develop, but there's also an aspect of implementing these therapies. So developing the treatments or developing the therapies is not enough. We have to be able to implement these therapies, and that's probably the matter for a completely different talk. But I want to put it in your brains as you think about behavioral change, not only understanding the mechanism of developing therapies, but also when you think about developing therapies, think from the beginning, how are these treatments, how are these interventions going to be implemented? I have put here just as an example, what is called the opioid use disorder cascade of care in the US, which shows that even though there are about 2.5 million individuals with opioid use disorder, only a minority are diagnosed, many fewer engage in care, many fewer get evidence-based interventions, and at the end of the day, only about 2% of individuals are actually engaged in care for time enough to really benefit. So hopefully in the discussion or in the panel discussion, we will be able to talk not only about mechanisms, interventions, but also about what kind of system, what kind of health system, or what kind of setup we need to again facilitate behavioral change, not only for one individual, but rather at the population level. Now, I want to go to the last few minutes to the last question. What studies are needed to make progress in this area? Well, I think we need a lot of, we could benefit from a lot of studies. And I go back to this slide where I put all the levels that influence behavior. And so our behavior is so complex, and sustaining behavior is influenced by so many factors that we need to really study it at many levels. Obviously, we have to get a better understanding of the genetic makeup and the biology that has to do with decision making. And this, as I mentioned, could be at the level of hormones and how different hormonal levels can influence behavior. Also doing brain imaging studies to understand to better understand both what structures are abnormal, but also the connectivity across different brain regions that have to do with decision making, with reward, with inhibitory control. It's also important to also understand social determinants of health, and this is a topic that fortunately has received more and more attention over the last few years. And also we need to do studies that analyze or examine how changes in policy can influence either positively or negatively changes in behavior. So is, for instance, legalization of certain drugs a positive development or a negative development? Are certain restrictions, certain regulations good or bad? How do we need to shape these policies? This is an area that is very important for research. One of the things that we are doing at the National Institute on Drug Abuse, again, just as an example, because we cover disorders across all levels, is the adolescent brain cognitive development study, and maybe some of you are familiar with this study. So what this study is seeking to do is follow up about 11,000 kids that were recruited when they were 9 to 10 years old, and to examine what happens over time to understand the normal brain development, but also to understand how drug use or other addictions can influence brain development. And so this is just an outline of some of the objectives of the study. As I said, study the individual development, develop national standards for healthy brain development, study how different activities and influences can shape the development of the brain. And hopefully those will give us new ideas on how to develop better preventive interventions or better interventions to favor change and sustain change. These are, I'm going to also show you some of the domains that are studied. And then the last type of studies that we need, as I mentioned, when I talked to about the US cascade of care, the opioid use disorder cascade of care in the US, is not only how to understand better the brain, not only how to understand all these levels of influence, but how to, once we have understood sort of the basis of behavior, once then we have understood how to modify behavior and sustain behavior, how to implement those interventions at a large level. So I want to stop here, just reminding you of how complex addictions are. I'm looking forward to the discussion with the other panelists, and again, to see how much of what I have presented here sort of overlaps or is different from other disorders. And I want to thank you for your attention and the organizers for putting together this very, very exciting panel. And I'm looking forward to the discussion and questions. Thank you.